Ma'am, we are live now. With all your permission, I'm starting this session.
Sure. Okay.
Good afternoon, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Anukrakti Dev Singla, ma'am. Let me share some of the achievement of the ma'am. Ma'am is a senior consultant, interventional pediatric cardiology and electrophysiology at Heart Care Clinic, Panchkula. Today, ma'am is going to speak on a topic, Holter Monitoring. Before starting this session, let me tell you overview of the topic. Holter monitoring is a non-invasive medical test used to continuously record a patient heart activity, including heart rate and rhythm. Over an extended period, typically 24 to 48 hours, this portable device, a Holter monitor, helps diagnose irregular heart rhythms, assess the effectiveness of medication, and monitor heart health during the daily activities. Healthcare professionals later analyze the recorded data to identify any abnormalities or arrhythmias during that part. By taking not much time for knowing more about this topic, I would like to invite ma'am and hand over this session to ma'am. Over to you, ma'am. Kindly proceed from here.
Thanks a lot for us for the introduction. And I would straight away start with our topic for today, which is Holter monitoring. And as you rightly said about Holter monitoring, the initial part that it is a non-invasive method which is used to detect various cardiac abnormalities, and it has been used since like long back, around 70-75 years, I would say. But today what we are going to do is go in detail of Holter monitoring, just not the non-real-time Holter which we used to know earlier, but the real-time Holter or real-time ambulatory cardiac monitoring. So let me start ambulatory electrocardiography was developed was to detect, first of all, document, and characterize abnormal cardiac activity. So there can be sometimes a detection, but like you see something on the monitor while patient is in your but you could not document it because there was no printout of the thing and the memory went off. The monitor could not store the data. So Holter monitoring, what it does, it detects as well as documents the abnormal cardiac activity. And you can easily differentiate whether it is atrial, ventricular, junctional, from where it is arising. So basically characterizing the abnormal cardiac activity is the important part of the Holter monitoring. So what it does, it actually extends the role of ECG. ECG is just like 10 seconds to 30 seconds. The patient is in your office and you are recording the ECG. You know, this is the abnormal cardiac activity, but whether it is happening at rest, whether it is happening at activity, how many times it's happening during a day. So all that information you will do only if you do the ambulatory electrocardiographic monitoring or the Holter monitoring. We all know that it was first done by Dr. Normal Jeff Holter, after which it's named Holter monitoring. And yeah, the present day nomenclature is ambulatory monitoring because its extended use has led to development of various techniques in the Holter monitoring. Let's go to the technical aspects first about Holter monitoring. So it would be surprising for you what was the initial weight of the Holter monitoring machine which Dr. Normal Jeff Holter made. It was about 38 kilograms, which he actually carried on his back while riding a stationary bicycle. But now today, modern day, we have about less than 500 grams of equipment, which is quite a good advancement as miniaturization of the equipment is considered. So we all know that modern devices, they're very light, they're inconspicuous. No one will know that you're wearing them and you can go to your day-to-day activities. That has helped in prolonging the time of recording from 24 hours to 48 hours to now 3 to 7 day recording, sometimes 2 weeks or 4 weeks recording as well. We get a continuous beat to beat ECG monitoring. There is an automatic arrhythmia detection, which is like a pointer will come when you are seeing the recording of the patient. There can be wireless transmission of data in near real time or real time nowadays as well. So it doesn't have to be all wired up. It can be just a patch on the chest of the patient, and even the transmission of data, it can be sent to you in near real time. So you know that the patient is having arrhythmia right now, or just like before 10 seconds or so, and you can intervene if required. It has improved diagnostic yield and provides enormous improvements in efficiency and ease of use. What are the technical advances which have happened over this period of time? The best thing is the miniaturization. The machines have become like the patient part has become smaller and smaller. So it is very acceptable for the patient to use them. The second is it being wireless. So having wires all around your chest is something which is quite unlikely to be used by patients with great enthusiasm. But yeah, wireless, you just put a patch or something. It's like very acceptable by patients. The third is the development of secure smart Bluetooth. So definitely wireless transmission of your ECG data. Also, some of them, they have multiple signal sensors. So apart from ECG, they can record your respiratory rate, oxygen saturation, your physical activity, temperature, your pulse pressure, and other parameters. So basically, if you're looking at a patient who's sick, who requires other evaluation as well, so it is kind of ambulatory vital signal monitoring, which is also possible from modern day devices. A very important thing which has happened is the real-time data or near real-time data, where the patient is wearing the monitor and you can see in real time what is happening with his heart right now. What is the electrocardiographic data the patient is going through right now? And if you need to intervene or call up the patient and say that you need to take your pill right now, or you need to do this right now, you can do it. And the last one is the automatic arrhythmia detection or alarm. So some of them are like patient triggered, some are auto triggered devices, which I'll go in detail when I go through the whole lecture. So these are the real advances which have helped the Holter monitoring system to become more acceptable, easy to use, and become very, very important in intervention. We have various types of recording systems. One which you already know is the standard Holter recorder, where the patient wears the leads and the wires are connected. There is a small cassette which records the data and it's transmitted to your device or your technician's device when the patient returns the cassette to the technician. The others are some are external event recorders or smartphone based recorders, where when the patient feels a symptom, he triggers that device, and at that time, whatever electrocardiographic abnormality or data is there is transmitted. Other recorders which have longer use are developed are patch, vest, or belt recorders, where the patient just has to place a patch on the chest or wears a vest which has textodes or electrodes inbuilt in that vest, or belt recorders. Other thing which is developed is event loop recorder. So a loop recorder is also a device similar to event recorder, I would say. Only thing is it records the event before and after the event has occurred. So when the patient realizes that, yes, I am having something like a palpitation or I'm going to faint, he presses that button, and or some are automatic which trigger on themselves, and they record the time frame in and around the event. If very long period of recording is required, then apart from the loop recorders and the vest recorders, we have mobile cardiac telemetry, which is not too much in use in India right now, but in near future, definitely it would be. Because of the cost issue, it is a constraint right now, but otherwise it's something which transmits the real-time data to you, and the physician can sit in office and look at the patient's telemetry, seeing what's happening to the patient right now. Very important in cardiac rehabilitation, post-procedure or post-surgery. And the last one is implantable loop recorders, which are for very long period of data recording. If there are very infrequent events, but the chances of events occurring in that patients are very high, like in inherited arrhythmias or in other modalities, then you can actually insert, which is invasive, which is implantable loop recorder. So just a pictorial view for all the type of ambulatory ECG monitoring we have. One is the standard Holter monitor, which I told you, which is having three set of leads or electrodes placed on patient's chest and a cassette. The second one is the event monitor, where the patient triggers or clicks on the monitor when he's having a symptom. Third one is the loop monitor. It's similar to Holter, only thing is the triggering and is available in the monitor. And all the event related data is stored for that time. Then we have a second generation Holter monitoring, which include the patches, vests, shirts, or belts, which have the inbuilt electrodes, which are called textodes. And then there can be ambulatory telemetry, which can be either real time or non-real time. So real time means the physician is directly seeing your telemetry. Usually it's in hospital settings, which the patient is in the bed and you're seeing the telemetry sitting in your office, while it could be non-real time where it's getting recorded, going to a monitoring station and getting transferred to you as a physician to report it and to act upon it. Now, various Holter, patch, external loop recorders, event recorders, and mobile cardiac telemetry have all different kind of advantages and pitfalls. So we should know that before choosing a device for our patient. Holter, we all are aware of that it is having the ability to record and document for longer, even longer periods of time. Only problem is the amount of data which will be needed to evaluate and analyze after the patient returns the cassette for you. So we have to judiciously choose which type of monitoring is best for my patient. The limitations of Holter is usually non-compliance because of the electrode fell off and then again you have to put and it goes away while you can't take bath. Otherwise, if you have to take bath, then you have to re-put the electrode. So all these things become kind of limited sometimes. So more acceptability has come for the wireless systems. That's why. Apart from that, yeah, they don't have a real-time data analysis. So even if patient is having a dangerous arrhythmia right now when he's wearing Holter, you cannot do anything about it right now. There are patch ECG monitors which are similar to Holter monitors. Only thing is there is no wires, so it's more acceptable. But it's because very closely placed electrodes, so the STT evaluation is not very accurate in the patch monitors. Also, we have external loop recorders and event recorders, which give very nice quality data. And also, according to the event occurred, they give data near the event when patient triggers the thing. But same way, the patient has to wear it like a Holter monitor all the time, the wired equipment. Even the patch ECG monitors are available, so definitely they are out of question for smaller kids. This I just wanted to show how internal loop recorder looks like. It's just size of a pen drive, which is inserted in front of the chest, just in front of the heart, and it records the electrical activity up to 36 months or 3 years till the battery is there. It is similar to, you can analyze it same as in pacemaker clinic. We analyze pacemaker patients. Similar to that, you can analyze the data. If there is any alarm, like if there is any arrhythmia detection, the alarm would come to the physician's office or the technician's office and can be acted upon. This is how external loop recorder ECG or recording looks like. Then we have mobile cardiac telemetry, or even in patient cardiac telemetry, where it is worn with the patient with same leads and wires. Only thing is it is transmitted to in real time to a computer which you can watch sitting in your office, and you can analyze the data. You can intervene on the patient's electrocardiographic abnormalities there and then. This is how a cardiac telemetry looks like. It's similar to monitor, which we have the multipara monitors in our hospitals, but it is more advanced, and you can calculate the QTC, see the initiation and the end of the arrhythmia, and all the alarms which you have set are stored. So you can even go back 7 days or 10 days back and see what happened. If you're not in office at that time, you come the next day, you can see what event happened with the patient at that time. This is how, if there is a patient with ICD or PPI. So this is an ICD data that can also tell you the event which happened in a continuous recording fashion. So now we come to the basic application, how to apply electrodes. We all know that you have to shave the skin, you have to remove the dead skin cells and use the electrodes. They should not form air in between. So there should be a space when it comes off. And obviously you have to give them extra set of electrodes. But nowadays, because everyone is having mobile phones, you can always click a photo after placing the electrodes and give the same to them so that they know where to place it when it falls off. We all use wet gel electrodes. You know, it's all silver and silver chloride element. And only problem with the electrode placement, if it's textured like in the vest carrier or shirt, sometimes the contact with the skin is not very good and you can have a lot of artifacts. The other part which we should see is electrode placement. If electrode moves away from the place, then there can be motion or motion artifacts which you can see. Artifacts are very, very important to know because they can actually present as pseudoarrhythmias. So you will see, oh, there is some arrhythmia in this patient, pseudoatrial or ventricular arrhythmias, they are called, because of loose connections or electrode contact, and the patient doesn't know that it has to be properly stuck to the chest. And sometimes the skeletal myopotential, if the patient is having some jerks or motion, or there is some noise in the area, then you can have something called as pseudoarrhythmias. It looks like arrhythmias, but actually they are artifacts. Sometimes the leads, they go off and you can have pseudo pauses, which can mimic like long pauses. And I mean, you can actually think that this patient is having electrocardiographic abnormality when it is just an artifact. So we should have clear-cut documentation, and we have to have a method to remove those things or exclude those things from diagnosis before going further. One important thing also, because sometimes what we have seen in practice, a patient comes with a Holter report and then he has some ECG from 3 months back, and we start comparing that what happened then and what happened now. So ECGs, the processing and of the ECGs and Holter is totally different. We cannot interchangeably use them. So it's not that this visit you used ECG and next visit you used AECG and next visit you use ECG. So if you're following up with ECG, you have to do ECG at every visit. Holter recording is something which has a different set of data which you want to derive from. So you should order for Holter, but apart from that, you should have ECGs also continuously for follow-up. You cannot use them interchangeably. And the processing similar to like pacemaker data processing, and they have to have band pass and notch filtering and remove the noise elements, the noise, respiration, body movements, tremors, so that the signal data is good enough to read. So after it is all amplified, filtered, and smooth, then you can analyze the ambulatory electrocardiography. So now we know that we have lot of things. It's just a talk on Holter monitoring, but we have a lot of things which have come up after the initial Holter monitor was drawn. We have event recorders, external loop recorders, implantable loop recorders, telemetry, implantable devices which can give you data for continuous ECG. There are wearable cardioverter defibrillators also. I've not seen in India yet, but yes, they are available. There can be patches and vests which can provide you continuous electrocardiographic data as well. Now we come to the most important part, which is indications, when to do Holter. See, if you have a test available, doesn't mean that you can order it for anyone. We should have a judicious selection of patients in which to use and why to use. We should know why we are doing it. So that is a very important part, and I am going to focus more because this is the wastage of Holter monitoring if you don't know when to do it and why to do it. So easy things, we all know that clinical symptoms, if a patient presents with syncope or dizziness, palpitations, That is the most common symptom when you will be ordering this test, the Holter monitoring test. Chest pain plus minus, because some of the patients with chest pain which are suspecting like a variant angina or something, maybe there is a role, but not in all chest pain. So I have put an asterisk there. But syncope, dizziness, palpitations, first and foremost, which we have been learning from our medical school, is that first is history, physical examination, and the basic workup. If that suggests that you can get some extra information from Holter, then yes, you should go ahead. But if the history is quite conclusive of a variant angina, would you go for Holter? No, not at all. So we should know in which syncope we are going to order it and which syncope we are not going to order it. Palpitations, you know that you saw a tiger in the forest and your heart rate goes up. You felt palpitations in your chest. Will you do a Holter? Definitely not. It's anxiety. You have a sinus tachycardia. You don't need a Holter. So history, physical examination definitely is the first thing. But we'll go in detail which syncope to order Holter and what to expect from that. Also for assessing prognosis of some diseases or for risk stratification. So there are some of the patients or ischemic heart disease patients where there is some role of Holter, and we'll discuss it. There is some non-ischemic dilated cardiomyopathies, hypertrophic cardiomyopathies, then ARVD, WPW syndrome, and inheritance system when I go further. Also in the antiarrhythmic drug therapy as well as a non-pharmacological therapy. So the pre-treatment assessment of any arrhythmia, especially the ventricular arrhythmias and atrial fibrillation. Also response to initiation, revision, or discontinuation of the drug therapy. For that, you might require Holter monitoring. And how it is required and how it is to be done, that we'll discuss when we go further. Then there are drug trials and safety, especially for QT evaluation. As we know, for class 3 drugs, they cause QT prolongation, especially if they're given with combination of class 1C. So you have to see QRS duration, QT, and everything. So for that, also we might require AECG monitoring. Implantable devices, very limited role, but yes, why to do and when to do, we can discuss when we go further. Let's come to the first commonest indication for doing a Holter, which is syncope. Syncope can be there due to bradyarrhythmias, as we all know, or tachyarrhythmias. Tachyarrhythmias, I would say supraventricular tachycardia is very, very rare to cause syncope. A patient can feel a bit of dizzy, but syncope, very, very rare, unless there is a heart failure which is accompanying in that patient. And ventricular tachycardias, VF and torsidis de pointis, definitely they can lead to syncope. Bradyarrhythmias, we should all know that only transient high-grade AV block, which is not seen on your ECG, can be picked up on AECG. Or if there is a sinus node dysfunction of any kind, which is causing syncope, that is also that can be found out on the ambulatory electrocardiographic monitoring. And what is our objective when we are doing an ECG, continuous ECG monitoring in the syncope patients? First of all, you should capture a serious arrhythmic event, which is sufficient to explain syncope. That is the first thing. Or you can have a feature which can suggest that there can be a serious arrhythmic event. Like you can have a substrate, a long QT, which was not very much seen on the ECG, but when you see in the day-to-day activities, maybe when the alarm rings, the QT prolongation is very much visible. Maybe you can have a substrate which can suggest a serious arrhythmic event. So either of the two things, either you see a serious arrhythmic event or a substrate for it, or you can exclude it. So the patient had a symptom, but at that time, you're not having any arrhythmia in the AECG. So it rules out that this can be the basis of syncope. So the most important thing is the patient should have a diary. And many patients forget to fill it. They say it's not important. Why should I do it? But that is the most important thing to do. Otherwise, you will not be able to correlate symptom with the rhythm.
Hello, ma'am. I request all the participants to be here patiently as there is some technical issue from the ma'am end. Ma'am will be joining us shortly. I request all the participants to be here. If you have any questions related to this topic, you can just post it on a chat box. After this session talk, we will take this question one by one with ma'am. Ma'am, you can proceed with the slides where you left.
You can hear me well, right?
Yes, ma'am, you are audible.
Really sorry for getting disconnected. Should
Yes,
be
ma'am, you can
our
proceed from.
sure.
Yes, ma'am, you can proceed, ma'am. Slides are visible.
So now we know that we have to do syncope and we have to either find a rhythm which is uh, responsible for the syncope, or we are able to exclude because there was no arrhythmia at the time the patient had syncope. So symptom rhythm correlation is the most important thing, and the diagnostic yield is better if you do for a longer time. They saw that about 87% yield if you do for about 2 weeks of Holter monitoring. But yes, it's not possible in real time. So usually we do a 24 to 48 hours, but you see the yield is only 22% in that. So we should keep in mind, we should not exclude everything if the Holter is normal, because the diagnostic yield itself is very low. So let's go to an example. If you have a competitive gymnast, 9-year-old presents with syncope, uh, what all you want to know about that gymnast when she comes with the history of 1 or 2 episodes of fainting while doing her gymnastic classes, because her symptoms occurred at peak exertion and she has a normal physical examination. This is her baseline ECG, if you can see. And you can all write the answers in the chat box, which is directed to me. Usually in such cases, we do exercise stress testing, and we also do AECG. So if you see, these are the results of her Holter monitoring. So you need to painting during her peak exertion. And what can you see on the Holter recording as well as on this exercise testing? This is during the peak exercise, which you can see. So these are some of the conditions which you encounter in day-to-day practice, and you will have to decide whether I need to do AECG and how will you interpret it. This is a kid 1-year-old who always went unconscious after crying for a long period of time. And you can see the Holter recording, how it shows sinus slowing and then a long pause. What do you think can be the cause of this? You can write your answers as well and send to the moderator. He will send it to me in the chat box. So there can be syncope or unconsciousness episodes depending on the age, or there can be dizziness, and you can find a variety of information in Holter recordings. The second common symptom where you order Holter monitoring is palpitations. Definitely a history, physical examination, and ECG. If they suggest, point towards an arrhythmia, definitely you will go for a Holter. If there is a presence of structural heart disease, you definitely want to go for a Holter, or if there is a family history of sudden cardiac death. If you know the patient has an inherited channelopathy which has a risk of arrhythmia, if that patient is coming to you for palpitations, even if the history doesn't suit, I'm saying you have to do a Holter. Sometimes you just have to reassure or tell the patient that your symptoms are not due to arrhythmia, it's just your anxiety or something. Those are some rare things where you can do Holter, but not a class 1 recommendation by the HRS and AHA. So best yield is definitely here also 2 weeks or more, but depending on the cost, the availability of the equipment, we can have it and the frequency of symptoms, we can decide how long we can do it for. So suppose this is a patient comes to your office and he says that he has this kind of palpitations on and off. You say that take a history and you don't feel that actually it fits into any of the arrhythmias. He goes back, he has an Apple Watch, he records his ECG and sends back to you. What do you think? You can write your answers and we can discuss at the end of the talk. So these will be the common things where the patients come with palpitations. You have to do Holter sometimes to exclude the diagnosis and sometimes to actually know what is happening. Now, this is one more recording from a Holter from a young boy athlete, and he has some symptoms of anxiety as well. He has palpitations, and this is his Holter recording. What do you think, and what do you think you should do if you see such an ECG? And this is a Holter of another patient with palpitations. So palpitations, you can have variety of arrhythmias. So I'm just giving you examples and we can discuss at the end what was what. But this is also a patient who gives you history of palpitations. You put AECG and this is what it comes up with. What do you think it is? And if you want me to play it again at the end of the session, we can do that as well. So palpitations becomes one of the second best indication to do a Holter monitoring. Then the chest pain and coronary ischemia. We all know that variant angina, still it requires provocative testing to go for intervention. But otherwise, to identify typical episodes of chest pain or to identify ischemic, it can be used, though the STT abnormalities are not as good as the normal current ECG, but still you can have all the channels STT changes at the end, and you can decide how much ST depression is there in daily activities. There are a few studies which actually document if there are changes in STT during daily activities versus on exercise testing, they have worse outcomes. So this is something for prognostication or prognostic value, not actually for diagnosis or intervention. But yeah, you can have a prognostication which patient with do better, who has a worse outcome and all. So this is how it looks like when you all must have seen the Holter reports. So this is how it looks like. The SC segment channel 1, it shows channel 2 and channel 3. So how much depression is there? And on the top, you actually get the overall 1 millimeter change. So we all know that it should be this much change for 1 minute before coming to normal. So all that will be shown in the Holter report. What we do usually, Holter reports, I have seen the residents sometimes reading the Holter report, they directly go to the rhythm part. They skip the first 3 or 4 pages, which has actually a lot of information which we should go through before going to the actual rhythm component of the recording. So in the ischemic heart disease and post-infarction, the important thing is if you have a patient who had non-ST elevation, AMI, and acute coronary syndrome, then whether the main question is whether the non-sustained VT you are seeing on the monitor is actually worth doing something. First of all, what it indicates, how it affects the prognosis. So the answer is, if the non-sustained VT you're seeing in a patient with a preserved LV ejection fraction, definitely you should look for risk stratification. If it is a low EF, we already know that myocardial scarring has happened. It is a substrate for ventricular arrhythmias. So it is not something which will tell you the actual prognostic value. But non-sustained VT alone, without taking an account for the ejection fraction of the patient, does not tell you that this is a worse outcome patient. Only if it is more than 8 beats, it's more than 120 per minute, it requires further exploration. Else, if it is more than 35% of EF, definitely you should do either stimulation program, stimulation to find out a substrate for sustained VT, or we can do AECG. But still, it's not a class 1 recommendation, which we'll come to later on. In the non-ischemic patients, which can be due to a variety of causes, as we know, viral, inherited, metabolic, toxic, tachycardiomyopathy, and all, we can have the prognostic value still, again, it's very low and controversial. But it becomes very much of prognostic value if you take abnormal QT dynamics and the ejection fraction into account. Important part is the negative predictive value is very high. So if you don't find any arrhythmia in AECG monitoring, I mean, it can be very highly reassuring that yes, the patient is not having anything. But the positive predictive value, very low. We have multiple risk stratifiers for the non-ischemic cardiomyopathy, which we can take into account while actually risk stratifying the disease. Hypertrophic cardiomyopathy, we all know that they can present with either syncope and palpitations, and syncope can be due to a variety of causes, not only due to ventricular arrhythmias, it can be due to LVOTO, it can be due to atrial arrhythmias with rapid ventricular rates, or it could be due to conduction abnormalities as such. So you can see variety of things in hypertrophic cardiomyopathy patients. So if the MRI suggests a myocardial fibrosis, which is diagnostic or which is quite high, or if the LA diameter you see on echo is more than 45 millimeters, the recommendation is to do AECG every 6 to 12 months. They say 24 hours by AHA, and the European Society says up to 48 hours. So that also has very high negative predictive value. If you do a 48-hour Holter and you don't see any arrhythmias, any NSVT, then it has a high negative predictive value that the patient is having symptoms due to NSVT. Now, arrhythmic right ventricular dysplasia or cardiomyopathy, they present with variety of symptoms, as you all know. They can even present with a sudden cardiac death. But if they present with syncope or dizziness or palpitations, or an asymptomatic patient, which is a family relative of a diagnosed patient, so you have to do evaluation at least yearly. You have to do Holter to see the development of arrhythmias. Some of them, they have arrhythmias like after 25 years, 30 years, 40 years of age. So you have to have a clear-cut demarcation for how long you're going to follow up this patient and how frequently you're going to follow up. What we need to see is the PVC burden, as defined by the burden, which is significant, is more than 524 hours. And the yield increases obviously when you put the Holter for a longer period of time. Also, if the patient has an ICD, then inappropriate ICD discharge can be prevented if you know why the arrhythmias, what arrhythmias are happening, and what drug therapy are required to control them. Suppose atrial arrhythmias are happening and you're having inappropriate ICD discharges due to that. You need to control the atrial arrhythmias first. So AECG will help you in defining which kind of arrhythmias the patient is experiencing. You can also get a signal averaged ECG from Holter, which is required for diagnosis of the ARVD. Wolff-Parkinson-White syndrome, we know that the properties of conduction pathways can vary. So they can conduct antigradely, they can conduct retrogradely, they can conduct both ways. But what we are worried about is they should not be conducting rapidly antigrade. Because if there is a development of atrial fibrillation and they are conducting antigrade, which is lethal to the patient because the AF risk will convert into ventricular fibrillation, the patient can have a sudden cardiac death. So exercise stress testing, definitely it helps us to find out sudden loss of pre-excitation at higher rates, and whether there is an intermittent pre-excitation. We can all see that in exercise stress testing, but ambulatory cardiac monitoring also can show us the similar data in day-to-day life when the heart rate goes higher, whether there is still pre-excitation persisting or not, and what is the shortest pre-excited RR interval, which should be less than 250, which we actually calculate in the EP lab. So if it is less than 250, we are safe that there should not be a high risk event with this patient. But what I have written in the last is there is no risk. So there's no risk. There is either low risk or high risk. So high risk if Sperry is more, if Sperry is low, then we are at least assured that incidence of sudden cardiac death or sudden event will be very less. So for counseling and for before procedure also, if you have any doubt or not, whether ablation is required, so you need to counsel the patient that way. Next in part comes the inherited arrhythmias. So we have bunch of inherited arrhythmias in our bucket: long QT syndromes, short QTs, Brugada, CPVT, early repolarization, and idiopathic VF. So idiopathic VF definitely a diagnosis exclusion, but all other things, we have to have our genes testing, we have to have our clinical testing, provocative testing if required to diagnose, and ambulatory cardiac monitoring becomes one of the tools for diagnosis as well as the prognostication of many of them. So what happens with the long QT syndrome? We all know the QT is more than 480. We have to fulfill the Schwartz criteria for long QT syndrome. But sometimes what happens is you cannot see the real QT RR relationship on your ECG. And some of the, like there are different types of QT syndromes, long QT syndromes, and some of them they require long period of recording of exercise testing to document the real QT, long QT phenotype. But AECG can also tell you the dynamics of RR and QT. So if there is a sudden change in RR interval, what happens to QT? Whether there can be a relation between R on T and the development of TDP. So long QT syndrome, and definitely if the patient is on beta blockade therapy, you want to do both exercise testing, sometimes AECG, to see whether there are any long pauses or short QT syndrome also, we know, yes, QT which is shorter than 340, but similarly for documentation of arrhythmias, we can do AECG. Brugada syndrome, we all ECG, but we all know that it's fluctuating. Very rare to see real Brugada ECG on a patient. Even if you have a family history, you're doing the family survey of all of the relatives, very difficult to see a real Brugada phenotype on the ECG. Sometimes they will be sometimes type 2 and going into type 1. So it's all a mix and match. But Brugada, you can have a look into various different types of arrhythmias which are there, or if there are any PVCs. So familial monitoring, yes, you have to do in Brugada syndrome, at least yearly for all a family diagnosed, a person diagnosed with Brugada, his immediate family members. CPVT, we all know that we can use exercise stress testing to actually see the arrhythmias which occur at peak exertion. But let me tell you with personal experience, sometimes, especially in teenagers and young children, where you cannot do exercise stress testing, you cannot come out with a real arrhythmia on exertion. Sometimes they have with emotional states. I had one patient who had a fight with his brother. He had a very serious fight and he went into arrest. His brother resuscitated him. He was brought into the hospital. After resuscitation, he was in a query neurological state for some time. After that, he got up. And the funny part was when he got up, his ECGs were showing pre-excited patterns. So he had WPW also, quite confusing. After ablation of his accessory pathway, because he had a sudden cardiac event, we had to, even if peri was high, we had to ablate that pathway. And after that, when we did that exercise testing, we could not see any arrhythmia as such. But then we did something which is called as burst protocol, a newer exercise testing protocol, and he showed uh, three ventricular beats altogether. And after that, it went on and on and on, and he had CPVT. So you never know when AECG can help you, a continuous ECG monitoring, and what all it can give you if you have a proper history and physical examination, and you have back in your mind that this is the diagnosis which I am searching for. Early repolarization syndrome also, there can be changes in the T wave abnormalities and the repolarization phase, which you can see on the ambulatory ECG monitoring. If there is a VF without any documented cause, and we know that genetic testing yield is very low. In Brugada, it's just 30 to 40%. So even if you have VF and you suspect that this patient is having Brugada, still maybe the genetic testing comes out to be negative. You have to label it as idiopathic VF. So all these conditions, we have a role for continuous ECG monitoring to detect the ventricular arrhythmias, to other substrate of arrhythmias, and for monitoring of these patients. Even in CPVT also, if you are giving a drug, so you have to see the effect of drug on Holter monitoring. This is one of the patients of long QT syndromes, which after getting up, hearing the alarm, had this episode and came to our office. This is the patient I was talking to you about, who had an arrest and found to be CPVT finally. So now we go to the patients with implantable devices. We all know that for device evaluation, we have enough acumen and the set of equipment required. We don't require AECG for device evaluation, but for need of PPI, whether permanent pacemaker is required or not, whether there is a long pauses, whether there are high degrade AV blocks, which are transient. So all that we have to see only on the ambulatory cardiac monitoring. Also, in a device which are already implanted, arrhythmia analysis is very important. Sometimes when the patient comes and you go through the arrhythmia channel in the monitor to see in the device check, it's not very clear. Was it ventricular arrhythmia? Sometimes they're very clear. Atrial arrhythmias, sometimes they are not very clear. Sometimes aberrant arrhythmias are not very clear. So you can order for AECG for seeing the type of arrhythmia and giving appropriate therapy so that inappropriate discharges don't occur. Also, to detect device malfunction, a patient comes to you and with implanted device, and you feel that device is not working or had a syncopal episode or so. So if your thresholds and all are good on the initial device testing, you can actually go through a continuous ECG monitoring, actually what is happening, what is the malfunction which is happening. So this is like my patient with post-COVID myocarditis who went on having this rhythm, and you all can see and decide what it is and write in your notebooks, and we can discuss at the end whether this is an indication of a device or not. This is a telemetry strip. This is also continuous ECG monitoring in hospital data. So if you see that the patient has a pacemaker, the black spikes are pacemaker. So you should be able to judge what kind of pacemaker was put in this patient. Is it working properly or not? Why there are different kind of rhythm I can see. So patient can experience palpitations because of this, or a drop beat or like this. So in implanted devices also, telemetry or AECG can have a role in telling you what kind of what device is working like, and is there any arrhythmia happening, and what is the etiology for arrhythmia. This is also an implanted device, And as you can see, there is all ventricular paced beats which are happening, and after that you can see that there is some arrhythmia, which is ventricular arrhythmia. Here the patient had feeling of missed beat or dropped beat, and you can easily see that the pacemaker is not giving the ventricular impulse. And why it is so, that all is a like a different topic. We can have a separate lecture on pacemaker malfunction and telemetry. So this is a patient who came with history of syncope, a device in situ, and when we did the device analysis, you can see he's losing his impulse at 3 volts. So his threshold was 3.25. He was set lower than that because the leads had some issue. Maybe he had heart failure or something. So the threshold goes up, and then he had a loss of ventricular impulse. The other important role of Holter monitoring is the pre-treatment assessment and then documentation of efficacy and safety of the drug therapy or ablation therapy which you are planning. So if we go for ventricular arrhythmias, if the patient has PVCs, you have to monitor PVCs to look for the burden of PVCs, whether they are high enough to cause a tachycardiomyopathy and heart failure. Then you have to see, if you start therapy, whether your therapy could suppress the ventricular arrhythmias or not. If you did a VT ablation, you have to see whether your ablation was successful or not. For all that, you need a continuous ECG monitoring, which is done by Holter monitoring. In atrial fibrillation cases, you have to see the rate and rhythm control, your efficacy of ablation if you did, or if you converted atrial fibrillation, you have to see whether there are long post-conversion pauses. Also for drug trials and safety. So this is 1 year old with congenital LV aneurysm, which came to us. I mean, we were following this kid from the fetal life. So you can see a ventricular bigymnia, 50% of PVC burden as such on the ECG. But yes, you need continuous monitoring to see actually what is the what are the episodes and how many PVCs this kid is having. Then when you start the therapy, you have to see how much you could suppress with the drug. So what we say is, if there are isolated or coupled PVCs, if you got 75% suppression in the PVCs on continuous AECG monitoring, so your therapy is good. If there are VT episodes, you have to have about 90% of suppression of those episodes to label your treatment as efficacious. Also, you need to see any other problems occurring when you are starting drug therapy. If there is a QT prolongation happening, if there is significant bradycardia happening for PPI, all those things will be seen only on the Holter monitoring. You also have to correlate whatever patient is complaining with the arrhythmia which is happening. Again, the symptom rhythm correlation. If you have ablated the VT or the patient has come after VT ablations, you should have at least a 30-day monitoring period after VT ablation with a automatic symptom trigger. When patient experiences a symptom, he can trigger it. These are for the patients who are without ICD, only VT ablation. If the after VT ablation patient is also having ICD, then definitely you will have the data through the ICD. In atrial fibrillation cases, you need to find whether there's a need for treatment, because most of our patients are asymptomatic. So is there any need for treatment in this patient? Are there any other causes of his symptoms? You need to do a Holter to see the rhythm over a long period of time. If there is a high density of atrial ectopy, so they are also trigger for atrial fibrillation. So it's defined as about more than 1,000 atrial premature beats in 24 hours. So there are like focal triggers which can transform into AF. Also, to reassure your patient that you're having this atrial fibrillation, but it has nothing to do with your symptom. I mean, nothing to do with your prognosis right now. So I don't need to do anything. So you need to do a Holter to see if everything is all right and not correlating with the symptoms. To predict the long-term prognosis in AF, also you need a Holter monitoring. And if you had a patient with a cryptogenic stroke, so you need either an ILR or a longer period to see if there was any atrial fibrillation, which is a cause for the stroke. So what we are looking for when you're doing Holter monitoring for atrial fibrillation patients, we have to see whether there is a rate control. At least 80 at rest and 100 to 110 on Holter is a good enough rate which you could achieve. Whether there is rhythm control, means is there a prevalence of atrial fibrillation with symptoms? That's important. Are there long post-conversion pauses? And then if you're starting a drug therapy, you need to see whether there is a QRS prolongation or AV block. If there's a class 1C drug, which can convert atrial fibrillation into flutter as such. And if class 3 drugs, whether there's a QTC prolongation. If the patient has underwent atrial fibrillation ablation, then you need to do a yearly Holter and regular event recorder. Where if they have any symptom, they can trigger the event recorder. So it also can detect non-AF arrhythmia. Suppose you have done ablation and patient will come back to you now, again, I'm having symptoms. How do you tell that patient that these symptoms are not due to atrial fibrillation, they are due to some other arrhythmia? So you need a continuous ECG monitoring for that. If in very early after AF ablation, within 2 weeks, you are seeing again atrial fibrillation on AECG, it means a failure of your ablation. You need to redo the procedure. Now there are some specific conditions where you will do Holter monitoring in like modern era. So there are many patients who are on dialysis or end stage renal disease. So we know that it as such can cause a myocardial stunning, and we can have various arrhythmias related to that. So in CKD patients also, if there are symptoms or there is a person with low ejection fraction, you should do a Holter monitoring. If there are neurological or muscular disorders, most common example would be a myotonic dystrophy. So if the muscular dystrophy you feel that is affecting cardiac muscle as well, then you have to do a Holter. Sleep apnea patients, usually they have various kinds of arrhythmias sometimes, which can lead to sudden cardiac death, but documentation is most important, and that can only be done by Holter. Pediatric age group, very specific thing is that they cannot use event recorders. We have to have a continuous recording. Wireless are very good, telemetry is very good, but if the gel goes off or the electrode goes off, you have to reapply. All those things are a bit problematic with the pediatric age group. In repaired congenital heart diseases for adults, as such, it's kind of a class 2 indication. But for pediatric age group, any patient who had a repaired CHD with a residual hemodynamic element, then you need to do a Holter to document that the symptoms are not due to arrhythmias. So this is one example of an ECG. So an infant, a post-operative AV block, VSD repair, had AV block. We see so many infants go into AV block, some of them recover, and we just put a temporary, sometimes a temporary pacemaker, and then they recover. But if the AV block persists for a long time, especially more than 10 to 14 days, then you need to put a permanent pacemaker, because already the scarring has happened and you know there is a substrate for AV block. So this boy, we had put a pacemaker. After that, the leads became dysfunctional, but his rhythm was always sinus rhythm. Had never had AV block. He was in close follow-up for Holter. So question can arise, if the leads were dysfunctional, why didn't you put a pacemaker again, like a lead again? So thing was, he was always in regular rhythm, just one PVC, if you can see in this Holter. Otherwise, he was having junctional at lower rates and or sinus rhythm at high rates. So close monitoring, but did not redo the procedure. So sometimes you have to make decision case to case basis. So the patient had loss of AV conduction at 10 days, but regained it after 2 days. But here we had already planted pacemaker by then. But the guidelines say, yes, you have to always put, because the AV block can come very late after 3 years also. So you have to monitor and you have to do a continuous Holter recording to document. This is a patient repaired CHD, which has, if you can see, atrial arrhythmia with 1/3 of the ventricular rate. And this is also one of the repaired CHDs. So you can always see there are two premature atrial beats which are triggering the supraventricular or atrial arrhythmias. The important part of the continuous recording is you can see the onset and offset of the arrhythmia very well. So what is the triggering factor and what to do for that patient, you can easily see, and then decide whether it is actually a sinus, it is a supraventricular tachycardia, how it ends, whether it ends with a PAC. So all that is very important, the continuous arrhythmia. Then this is also one important part which we all see in our Holter reports, heart rate variability. Heart rate turbulence, QT dynamics we don't see that much. But yeah, QT dynamics is important part, difficult to assess because we don't know where the T wave is ending. The slope of T wave differs, the T wave amplitude differs. But heart rate variability, yes, has been used for a long period of time. We all know that how it looks like. So this is a standard Holter report where you see the heart rate, the ectopy, the ST segment analysis, and the heart rate variability. So we know the standard deviation of the end-to-end interval in 24 hours, and we know that it should be more than 100 milliseconds. So basically, it means that when you're doing activity, your heart is able to adapt to that situation. It should increase the heart rate, right? It should not be the similar heart rate because that becomes a worse prognostic factor. So it was found in the studies done like long back in 80s that if you have an SDNN of about 50, then you have a five-fold more risk of having a worse outcome. So this is how it looks like, heart rate variability and the QTC. This is the QTC variability, which you can see in the 3 channels. And these are the very low frequency, low frequency. I mean, this is a completely different topic if we start talking about these terms, but what we know that heart rate variability is an important factor. We should see whether the heart rate is changing in day-to-day activities or not, or it's remaining stationary at a particular place, because that is something which is going to predict a worse outcome in our patient. Heart rate turbulence is something which we know that it's, if it is only more than 5 PVCs, you can assess that, which is a baroreceptor response, which we are assessing. And I think we are running very short of time, but so I'm going to end very fast. So after all this, which we have learned, we know what are the class 1 indications of doing a Holter and what to look for in, I think you should be clear in that. So this is a repetition of the same: syncope, palpitations, WPW, transmetal angina, cryptogenic stroke, newly diagnosed non-ischemic cardiomyopathy, NSVT in HCM patients, quantification of ventricular ectopy, and in ARVC, antiarrhythmic drug monitoring, and repaired CHDs with residual hemodynamic abnormalities. These are all class 1 indications of doing Holter monitoring. While the class 2A are atrial fibrillation detection, quantification, and seeing the post-conversion pauses and post-treatment phase. Implantable devices to see the device malfunction if the device interrogation is not definitive. Healed MI, which have a preserved EF to detect the non-sustained ventricular tachycardia episodes and risk stratification, because they are the candidates who will go for ICD. Also, the assessing of arrhythmia suppression, and in the adult congenital heart diseases to assess the arrhythmias and conduction disturbances. These are all class 2A indications. We all know what is class 1, class 2A, and class 2B is NSVT after MI in reduced EF patients. It doesn't have any value as such, so it goes into class 2B, and risk classification in non-ischemic cardiomyopathy. Device selection, which one to put and how long to put, it all depends on the ease of use, the age group which you are looking for, and what information you are looking for. According to that, you can choose, which we already have actually discussed in detail in the earlier slides. The duration, you can assess the frequency of symptoms and the nature of disease. So if frequency is very frequent, even 24-hour would help. But if it is very rare, so you might have to just go for ILR, which is 36 months. But otherwise, a longer recording would have better yield. So this is a quiz for you. If you can tell me what's the diagnosis, and we can have it at the end, these two. So I can hold it here for some time. You can assess what it is, and then we can take the question and answers. So this one, and what is your diagnosis on this one? If you want, I can replay while we're doing question answers. So I try to be very quick, yet I try to cover most of the things. And I would like to listen to your questions and try to answer if possible. So for us, we can take the question answers and the answers for the quiz, if possible.
Okay, ma'am. Thank you so much, ma'am, for a wonderful presentation. I hope this knowledge is going to help all the participants who have joined this session, ma'am. As I
Sure.
can see, ma'am, we have received some question from the participant, and if you allow, with all your permission, ma'am, shall we take these questions?
Yeah, I mean, you're putting in the chat box or you're telling the
No,
question?
ma'am, I will ask, ma'am. Dr. Agnihotri is asking, what ECG electrodes brands do you find to for the ideal monitoring for a long-term period, 2 to 3 week?
I mean, it doesn't depend on the brand. Actually, I'm not brand specific. Any of the electrodes are good enough. Only thing is the application should be proper and you should always give it. Depends on the patient. If you're sweating too much, then they will definitely fall off. If it's a pediatric patient, it will fall off. So I don't go with any brand and I don't recommend any brand. It's just that you have to provide a set of extra electrodes to the patient and tell them the placement, where to put it.
Thank you so much, ma'am, for replying. I hope that Dr. Agnihotri has received his answer. Moving forward, Dr. Abhilipsha is asking, with an HRV 24-hour protocol, how do you define the day and the night period?
Usually it's an 18-hour recording which we have in the heart rate variability, which includes night. So I don't understand her question very well, ki why you do day and night period, because you will always see the time on the Holter recording, right? According to the time, you can see the variability which is happening during the night and day as well. So I don't know why she is asking that, because it's a total variability which we are calculating, which should be more than 100. It accounts for the sleep and the night period as well. So why you want to know which is night, which is day? It's an 18-hour period and we are calculating according to that.
Okay, ma'am. Thank you so much, ma'am, for explaining it, ma'am. I can see another question from Dr. Sivesh Sinha. He is asking, do you have experience with transcranial Doppler Holter monitoring?
I don't have, I'm sorry. I have done transcranial Doppler and transcranial ultrasound as well, because I am a pediatric person from the background, but transcranial Doppler Holter, no. And there is no standardized thing such for that as such. So I don't recommend that as well.
Okay, thank you so much, ma'am. And one feedback from Dr. Manoj. He's writing wonderful presentation and well explained. Hope to help in our practice too. And I hope that Dr. Manoj really enjoyed this presentation, ma'am. As I
Thanks
can
a
see,
lot,
ma'am, there
Dr.
is no,
Manoj.
yeah, ma'am. As I can see, there is no more, ma'am, questions from the participant. And if you allow, with all your permission, shall we conclude this session, ma'am?
Sure, no one has answered to the questions which I
Yes,
asked.
ma'am. Yes, ma'am. The quiz answer is not yet. We have processed,
Okay,
ma'am.
okay, sure.
I was
No
refreshing
problem.
also, but didn't
Okay.
receive the answer, ma'am.
So I
I
would
hope
like to
that,
actually
ma'am, it will
give
be
the answer
posted on
if
the portal, ma'am. Yes, ma'am. It
yeah, so
will.
I can post the answers if they want. I'm not sure whether they actually went through the ECGs and all, but yeah, if they want, we can always have a session on the question answers of for the quiz if you are
Sure, ma'am. We
posting
will
the ECGs on your
definitely we
portal.
will have. Like, ma'am,
Sure.
it will be posted, and after that, there will be lots of people who will ask watching after the session, like on the
Okay.
portal. If they
Sure.
also comment on that, we can have a like if we have a huge numbers, we can have conduct a session particular for that, ma'am.
Great. That's nice. That's nice.
Yes,
Okay.
ma'am. Thank you so much, ma'am, for your time, ma'am. Hope to see you again with different topic in coming times. Till
Sure.
then, take
Definitely.
care of yourself, ma'am. It was a wonderful to have your time and your presence, ma'am.
All my
I
pleasure.
hope that it
Thank you.
being a very good.